Patient Center Electronic Health Records Committee. We are here today as a group to discuss and collaborate as a team the best methods for Mr. Lister's health condition. Once he is stabilized from the ICU to the med-surg and the transition to discharge from home with the integration of intensive insulin therapy and clinical decision support system, and the effective means of communication with ICU and med-surg, Mr. Lister, and the use of technology. Our committee members are myself, Elda, the member representative. We also have an ICU nurse, Danny.
Hi, I'm Denny. So in addition to being a member of the Electronic Health Record Committee, I've worked for DRHA for several years in the critical care unit, and I'm happy to be part of this discussion today. Thank you.
And we have another ICU nurse, Jennifer.
Hello. Nice to be here.
And Katie, who is not present, but she had given us a little outline of her thoughts on Mr. Lister's care, which I will be sharing with you. She's a med-surg nurse. And we also have Russell, our case manager for both departments, ICU and med-surg.
Hello, my name is Russell, and the majority of my background is from experience in med-surg, so we'll see if we can contribute here today.
I have a code here that I wanted to start off before we start our discussion on Mr. Lister's care, and it's a code from an article found in the Cancer Journal. It states that the key to harnessing the potential of informatics to promote patient-centered care is to use technology to direct both patients and clinicians high-quality information and to share this information with one another. The following will be discussed on the best way to managing Mr. Lister's care and the use of technology that will be controlling his glucose at home, the use of override with the clinical decision support system, use of PDA and communication between nurses, and other technology devices that help with patient transfer of care between the emergency room, ICU, med-surg, and to home. We'll have Jennifer start off by sharing what she would like for Mr. Lister.
Hello again, my name is Jennifer. I'm one of the ICU nurses, and I'm also going to, outside of discussing Mr. Lister's care, I'm also going to discuss some technology which we can look at utilizing inside the ICU to better manage Mr. Lister. So as we all know, Mr. Lister is a existing patient of DRHA, and our plan is to stabilize him inside the intensive care unit with a transition eventually once he stabilizes into med-surg, and then stabilizing him there and hopefully being able to get him back home where he's more comfortable and at ease and can go back to basically having a great life. So with that being said, Mr. Lister, so alongside monitoring the glucose levels of Mr. Lister, the staff needs to be cognizant of factors and comorbidities that contributed to his initial admission. What we know about Mr. Lister's medical history is that he's a diabetic. He has heart failure with a corresponding ejection fraction of only 30%. He has cancer and has had some instances of prior falls. While stabilizing his glucose level is crucial, the staff needs to monitor his cardiac status, seeing that he also has, he's having episodes of an irregular heart rate, and also be aware of any safety concerns such as confusion, which may prompt him to pull at essential treatment and monitoring lines, or even climb out of the bed, which may cause undue injury to him. In instances such as these, technology can assist the staff with the monitoring necessary to limit unsafe situations from occurring. Current monitoring includes the use of a vital signs monitor, which allows staff to observe the patient's current blood pressure, heart rate, respiratory rate, and oxygen saturation. The monitor can be programmed to capture up-to-date vital signs on Mr. Lister to keep the staff apprised of any changes or important findings that may be an indicator of his declining health status. The monitor itself can be preset with limits to notify the staff if there is any substantial change in his vital signs. In some hospital environments, technology has the ability to automatically upload this information into the patient's electronic health record for all to see and analyze. In addition, monitoring of an at-risk patient who is attempting to crawl out of bed would employ the use of such technology as a bed alarm to alert that an unsafe situation is about to occur when family or staff is unable to sit at the bedside to ensure a patient's safety. Furthermore, evidence-based practice recommends the use of telenursing to assist in the monitoring of an at-risk patient. In the publication authored by Williams, Hubbard, Dye, and Barden in 2012, entitled Telenursing in the Intensive Care Unit, Transforming Nursing Practice, the authors describe telenursing as the use of technology to provide nursing care and monitoring remotely by exchanging information from one site to another in order to improve a patient's health status and overall outcome. How this is achieved is by the use of a video camera to observe the status of a patient from a remote location. The telenurse works in conjunction with a bedside nurse to assess the patient's physical appearance, equipment safety, running infusions, and other environmental factors when the primary nurse is unable to do so. Assessments of the patient are predetermined based on a acuity level, which is established by the patient's current health status, their treatments they're receiving, and evaluations necessary to ensure their recovery. If the telenurse observes a situation that may be pertinent to the patient's recovery, he or she is able to notify the primary nurse or the physician promptly as to the circumstances which may cause deterioration in a patient's health status. Having a second set of eyes to collaborate in the recovery process has the propensity to reduce the number of health status events and the number of inpatient days spent in the hospital, thus decreasing the overall expense incurred for the patient and the hospital as well. So at this juncture, what I would like to do is forward it over to Denny, who is going to elaborate on some measures that we here in the ICU take to be able to stabilize Mr. Lister's glucose levels.
Perfect, thank you. So yeah, I'll talk about some things that we're using currently for Mr. Lister, and then how we hope to transition patients like Mr. Lister into the medical surgical units where they don't use the same systems that we use, and then ideally promote a safe transfer for Mr. Lister and patients like him to go home safely. So in the critical care unit, we've begun using a system of blood glucose control known as intensive insulin therapy, or IIT. IIT is used alongside a clinical decision support system, or CDSS, which incorporates protocol and the administration of medication associated with the IIT. This is a nurse-driven treatment which combines frequent blood glucose measurements with insulin titrations. For those of you unfamiliar with the programs in practice, I'll go over the basics. The bedside nurse, with the goal of keeping the patient's blood glucose around between 80 and 110, enters the patient's form of dextrose into the IIT. If there's no dextrose entered, the IIT will inform the nurse to run 10% intravenous dextrose. The nurse then checks the patient's blood glucose every 1 to 2 hours, depending on the physician's order, and immediately enters the value into the bedside computer system, which runs the IIT program. The CDSS will then run through an algorithm determining the appropriate amount of insulin, if any, the patient is to receive via intravenous insulin pump. The current system does not allow the nurse to does allow the nurse to override the recommendation calculated by the CDSS. I can't deny that the nurses in our ICU do have mixed feelings about the system, feeling that their ability to critical think through patient scenarios is reduced. The majority of the staff, however, find the system very user-friendly and safe for the patients. According to a 2011 study by Campion, May, Waitman, Ozdas, Lorenzi, and Gadd, found on group.bmj.com, factors that can affect IIT performance include patient populations, techniques of glucose monitoring, blood glucose target ranges, nutrition provisions, and nurse staffing ratios. Although the medical surgical units aren't currently using the IIT CDSS, the electronic health record clearly displays the patient's blood glucose values and associated treatment provided while on the critical care unit. The information can be easily accessed via the computer tab, which is labeled glucose monitoring. Prior to the transfer of a patient to the med-surg unit, the patient is transitioned to traditional blood glucose monitoring. The handoff process includes nurse-to-nurse communication regarding the current and predicted future blood glucose therapy. Eventually, while on the med-surg unit, the patient will transition to their home regimen of glucose monitoring and insulin coverage, ideally providing for a safe transition back into the home environment. So at this point, I'll hand it back to Elda, who's going to discuss some of the handoff methods that Katie's researched for this discussion.
Thank you, Denny. Katie wanted us to share her critical thoughts of handoff between patients' care from ICU to med-surg and the use of handoff with PDA. Handoff between the ICU nurse and the med-surg floor is critical for this patient, Mr. Lister. We all know the handoff between nurses is very dangerous, and misinformation can greatly affect patients' outcome. In this scenario, it is essential. In this situation with Mr. Lister, essential the ICU nurse handoff is accurate information regarding the patient's hospital course and intervention. The use of the bedside handoff and PDA's personal digital assistant will help the nurse to communicate more effectively. A study of PDAs found that handheld computers appear to provide easy and timely access to information and to support more accurate and complete documentation. Using a PDA for handoff in Mr. Lister's care will allow the nurses to review orders in real time, Mr. Lister's most recent labs and vital signs at the time of report in order to facilitate an accurate, complete patient handoff. The nurse will also review the plan of care and what interventions will be used in the ICU. Now I turn it over to Russell, our case manager.
Thank you very much for that. I'm just going to go over a few minor things with a little bit of the technology and the transfer of patients, as well as looking into discharge. The electronic health record, if in use, should remain the primary technological device that would help with the transfer of patients between units and floors. If used properly, the EHR provides the user with access to a patient's history, diagnosis, previous hospitalizations and treatments, as well as imaging, medications given, and current health trends. The use of a PDA during handoffs could be useful to highlight current trends. However, having a second device or computer screen to look through could add to some confusion and slow down response times. Copies of printable sheets could also be included, for instance in the case of Mr. Lister, where the ICU was using an ITT program where the medical surgical floor did not have access to that. All in all, a detailed handoff between the units with a properly documented EHR should be sufficient in most cases. As the Snyder et al. Study states, the goal of patient-centered care is that care should be coordinated within and across hospital systems. Turning to the discharge home, I would like to point out what Moore and Fisher stated in their 2012 article, Healthcare Information Technology and Medical Surgical Nurses, where they said the value of technology is not determined by the technology itself, but rather by the user's appraisal of it. Although there are many technological options available during discharge, the first thing to consider is the user's comfort and use of technology in their everyday life. The Snyder study stated that they found that individuals with lower household incomes of, say, less than $30,000 a year and or education less than high school reported lower internet use. Also, there are still people in areas around the country that do not have access to electricity and running water, so this should be considered as well at time of discharge. A few simple questions can be asked to the patient to determine comfort and use levels of technology, such as, do you have an email account, and do you check that email account on a regular basis? Or, do you have a smartphone, and are you able to navigate applications upon it? These simple questions can determine whether we need to discharge the patient with either standard paper printouts of information, emergency signs and symptoms, and what to do, or whether or not they are available to use some of our more technological uses. If the patient is comfortable with technology, there are several options, including access to the hospital's web portal. The Snyder et al. Study states that patient portals is a good means of communicating with physicians, arranging appointments, and to get prescriptions refilled, but should not be used in emergency situations. The web portal will have information on the CHF and diabetes, what it is, what it does, what an emergency is, and what to do about it. Mr. Lister, who also has a history of compliance with his diabetes, will be able to keep and track record of blood glucose levels, insulin, carbohydrate intakes, as well as his own personal well-being during this medical change. A copy of this portal information could also be sent to Home Health, as Mr. Lister was found down by his neighbors, which brings up the question of does he live alone If he does live alone, then home health can make arrangements for checkups as well as contacting his neighbors so they can make arrangements for checkups. Then if he's also alone, they can also look into making arrangements for a wireless first alert communication, and these devices can help him to, to call help if needed. These suggestions represent a fraction of available resources that already exist and are available to healthcare workers and the general public in use. The key is to match the technology with the patient, and as the Snyder study stated, patient preferences should be respected when choosing the level of technology to integrate for this assignment. Once we have this patient's preferences, we'll be able to continue and actually make a more detailed personal level of his care. If anybody has anything else to add, I'd like to turn that back over to Elda.
Well, thank you, Russell. Great information for Mr. Lister. Based on our discussion and purpose of this meeting, it seems like we have formulated great ways of communication, the best ways of communication between the ICU and med-surg, and proper management for Mr. Lister and follow-up of his care, as well as for any future patients in the use of technology. Through the electronic healthcare record, I have a quote here from the Cancer Journal. It is an important clinical tool to enhance the Institute of Medicine principles of patient safety, timeliness, and efficiency, as well as patient-centeredness. With all this, we're hoping to progress for future patients and make technology more available for them and better communications within the departments. Any other suggestions?
We're good?
No, thank you for your time.
Thank
Thank
you.
you.
Thank you.